Thank you, Dr. Shushmita, for having me here today, and good morning, all of you. Um, I'm going to take you through an overview of the wound healing process after surgery. Okay, so what's different? Why are we talking about wound healing? Wound healing in glaucoma surgery is a yes and no deal. We would like the wound not to heal, but we would like also the wound to heal a little bit, but not too much. That's what we're constantly struggling with in the post-operative phase. The wound healing starts almost immediately that you complete the surgery, and that's when your struggles begin. If you take a look at this diagram, it's very simple. When you're cutting up the conjunctiva, already there is leakage of blood and there is fibrin formation, and then the inflammatory phase starts immediately, followed by the proliferative phase where the fibroblast proliferation takes place, and the remodeling phase where there is granulation tissue, scar tissue, wound contraction, and you know the pressures are going up at this phase actually. When we take up a patient for glaucoma surgery, one must remember that topical anti-glaucoma therapy leads to conjunctival and Tenon's inflammation. This was demonstrated in the early 1990s and perhaps in the late 1980s too. And patients treated with FML before surgery had a much higher chance of surgical success compared to in the untreated group. And that's because when you use steroids, you reduce the conjunctival and Tenon's inflammation that are caused by the anti-glaucoma therapy. At our institute, we tend to stop the prostaglandins and the alpha agonists 5 days prior to surgery and pre-treat with steroids. Only beta blockers and systemic carbonic anhydrase inhibitors are used prior to surgery. This is an example of what happened to one of our patients almost about 7 years back when we took up surgery and he was on prostaglandins and maximal medical therapy. And this was the situation even post-op 6 weeks following surgery, and the first few weeks were terrible with the tremendous amount of subconjunctival hemorrhage and conjunctival congestion. So it's very, very important to switch the patients of prostaglandins if you want the healing to be a little bit down post-operatively. Now there is a high possibility of trabeculectomy failure if operated within a short while after the first incisional surgery, may it be a trabeculectomy or something else, and therefore there needs to be a cooling off period before you take up the second surgery. Many of these second surgeries would fail within the first few months, but that has now changed a little bit because of the use of mitomycin C. Remember that even one prior surgery tends to reduce the surgical success very significantly. And this is a patient that I'm showing just for example, that if you have a patient like this post-operatively for whatever reason, don't rush into surgery if it's not really necessary to reduce the intraocular pressure. That means if the pressure is not very high, just hold still, start steroids, reduce the congestion. With this degree of congestion, it's almost a certainty that the surgery will fail actually. The effect of steroids on wound healing is well established, and it's almost a certain that steroids should be given post-operatively, although there are reports in the literature suggesting that if we could avoid steroids and give non-steroidal anti-inflammatory agents, would that be better? 5-FU injections given subconjunctivally were beneficial, but the regime was complicated. Intraoperative 5-FU may be used in low-risk cases. Mitomycin is something that many of us use, and it inhibits fibroblast proliferation and endothelial cell growth, and we use it at varying concentration, but generally at 0.4 milligrams per ml for 2 to 4 minutes depending on what the surgeon prefers. While mitomycin C increases the success rate, the most potent complications are late onset endophthalmitis and hypotony that all of us must remember. And this is a patient that in the early days when we shifted to the filter paper technique and we realized that we were trying to control the amount of mitomycin we delivered, but you can see the amount of pallor that we got in this, and this is a classical ring of steel that has been described in literature, and this is the junction where the blood vessels can't encroach upon, so there's a lot of fibrosis here at the junction and lot of redness here. So even though the bleb is working fine, the intraocular pressure is under control, but this is not really what you want to do to a patient. And these are just photographs that you can get endophthalmitis as a significant complication of having used mitomycin C. So what are the sites of wound healing and therefore wound modulation? The cut conjunctiva, the tenons, the bleeders, the blood, the episcleral tissue, the edges and the surface of the deep sclera, the sclerostomy, the sutures to the scleral flap, sutures to the tenons and conjunctiva, and border of conjunctiva between mitomycin C exposed part and normal conjunctiva. Shushmita, do let me know if I exceed time. Now, take a look at this. This is the cut edge. Please make a clean cut edge when you're making the scleral flap. It will reduce your healing. And this is the bed of the flap. That's another side. Please try and make as clean a dissection and even cauterize the vessels if required here. And these are the blood vessels that bleed, and you need to take care that you try and decrease bleeding, and sometimes we do that by using alpha agonists topically before you start treatment. And this is the episcleral tissue. If you look carefully, even after you've cauterized, if you use a small forceps, you can pick up episcleral tissue, and these are all foci that can lead to healing. And then this is the sclerostomy, and of course, because you have a cut edge here, and that can lead to healing. And these are sutures, and I will show you photographs of how subconjunctival suturing of the scleral flap is also a potent site for attracting blood vessels, and therefore everything that comes with the blood vessel. And this is suturing of the conjunctiva, and you form a nidus of inflammation and wound healing because of the sutures that you pass through the conjunctiva. Now, these are the sutures that you can see just underneath here lie the sutures given to the scleral flap, and you can see the pattern of the blood vessels that are drawn. These were not present before the surgery, and these happened after the surgery. And these are small, tiny sutures that have attracted this large blood vessels. Tiny sutures will attract large blood vessels, and large sutures will play havoc with the surgery post-operatively. And I just want to show you a pattern of healing with Ologen and Avastin. And this is a bleb, and you can see here that in this area the Ologen was placed here, and this is the exposed area to the scleral flap. You can see that the vessels are coming by the sides but haven't grown into the conjunctival area, and perhaps that is a good thing for the bleb. And this is a conjunctiva that gave way. There was nothing wrong with the surgery, it was perfect, and the conjunctiva just melted, and you can get these spots of melt just where you draw the conjunctiva over the limbus, or sometimes at the cut edge of the conjunctiva just tends to melt away, and we need to be cautious about this actually. And this is an example of bleb infection following F5 FUUs that led to healing, and we were very fortunate that we were able to control this simply by giving antibiotics and following over a long period of time, and we were extremely fortunate. So prepare the patient for surgery by modulating the tissue response, spend time during surgery, use good instrumentation, cauterize the bleeders well, clean the area around the wound well, use the smallest suture material, and it is preferable to use 10-0 vicryl where possible. All sutures are foreign bodies and excite a tremendous response. So the importance of the suture, try and shift to vicryl. Conjunctiva and tenons complex, use mitomycin C. The scleral bed needs clean dissection. The bleeders, pre-treat with alpha agonists and steroids where possible, and coagulate them well intraoperatively. The conjunctival vessels, we have no obvious workable solution really, because as soon as you cut the conjunctiva, you often see bleeding, and you'd like to avoid that. Post-operative healing, you have massage, suturolysis, and needling. Thank you all very much.